it's my pleasure to introduce Dr. Karen Heichman. Dr. Heichman is currently the Senior Program Officer for Diagnostic Development and Innovative Technology Solutions in the Global Health Division of the Bill and Melinda Gates Foundation. She has been in that role since July of 2018, and she has focused a tremendous amount of her energy on leading development of efforts for diagnostics for tuberculosis globally and evaluating a variety of novel diagnostic technologies for global health. For the past few months, she's devoted the majority of her time for the efforts for assessing and validating a number of novel and sustainable methods for specimen collection for COVID-19. And she will be presenting today on that topic, and with the title of her talk being Home Collection of Nasal Specimens, Lowering the Barrier to SARS CoV-2 Testing and Expanding Access to Healthcare. Dr. Heichman, I'm going to turn the podium over to you, and thank you for joining us today.
Great, thank you so much, Carl. It's really a pleasure to participate in this meeting, and it's so nice to see so many familiar names and hear the voices of my former colleagues like you from ARUP, including Dr. Slev, and also really exciting to be able to participate in this with my new colleagues that I've been working with in infectious diseases. So thank you so much for this opportunity. The work that I'm going to tell you about today is really the efforts of many different groups who have been looking at alternatives to the traditional nasopharyngeal swab specimen for testing in SARS CoV-2. And from the foundation perspective, we're really interested in this idea of an alternative specimen type because it has the potential to expand access to testing and to care. The first slide here really goes through some of the barriers that I think I probably don't need to reiterate with many of you, but I'm sure that you can appreciate that in the early weeks of the SARS CoV-2 epidemic and now pandemic, there were a number of barriers to specimen collection that needed to be overcome. One of the first barriers to specimen collection and to testing was issues regarding transportation of symptomatic individuals to healthcare facilities for testing. Not that necessarily the transportation was a barrier, but the fact that patients needed to come in for testing, and there was really a lot of confusion about how to get testing, where testing was available, and concerns around transmission of the disease to others in the course of obtaining testing. I'm sure you're all very well aware that the swabs that were used in the original days of testing were limited to nasopharyngeal and oropharyngeal swabs, and that those swabs have only been manufactured by a small number of suppliers, including one that's based in Italy that was facing its own challenges. The NP swabs are also limiting because they require a professional for collection. And so by having to insert the swab up through the nasal cavity to the nasal pharynx, it really requires a professional to do this, and also it potentially exposes that professional to transmission of the virus. It's also very uncomfortable for the person who's having that specimen be obtained. As you can appreciate, the potential for exposure to the virus prompts the requirement for PPE. And I'm sure you're all aware and familiar with the limitations on PPE and the shortages that were experienced in the early days. I think now the protocols for using PPE have expanded to multiple different uses, but in the beginning days, it was the traditional that people were changing their PPE during the times that they were collecting specimens. In addition to the shortages on the swabs, there were also shortages in the transport media that was being used to transport and stabilize the specimens from the site of collection during the transport process to the lab. And there were a number of efforts underway in those early days to identify whether alternative types of transport media could be used in the absence of a large supply of VTM. And finally, the collection of the specimens in some of these non-traditional settings, such as in a drive-through clinic, really required the requirement for maintenance of cold chain for those specimens prior to the time that the specimens would be sent to the lab for testing. So at the Bill and Melinda Gates Foundation, we really wanted to understand better whether it might be possible to get over any or all of these particular barriers, really with the notion in mind that it would be very advantageous to have a scenario whereby a person could collect their own specimen at home, thereby enabling increased testing and access to alternative types of tests that might be available in low and middle income countries. The next slide is really a summary of a large body of work that was conducted by two different groups at the same time, and these were partners of ours in those early days. The work shown on the left was performed by the Everett Clinic, which is a series of clinics in the upper Puget Sound area in the state of Washington, and this was really the site of the original outbreak in the United States. This work was conducted under the guidance of Yuan Po Tu, who is an upper respiratory physician and who manages the series of clinics there. This study was looking at patients that were coming to the clinics with upper respiratory symptoms, seeking testing for SARS CoV-2. The method of testing in this clinical setting was the traditional nasopharyngeal swab. But in this study, alternative swab collection sites were performed, which included a nasal lower nary swab collection, as well as collections to the mid-turbinate region, as well as a collection from the tongue and oral scraping. The patients were then tested for clinical purposes with a positivity rate of about 10% during that time in that Seattle area. And you can see here really the summary of a large body of data that looks at the comparison in the same patients that had received nasal collection that was a self-collected specimen in both nares as compared to the nasopharyngeal swab. And you can see here that there was 94% positive percent agreement between the nasopharyngeal and the nasal swab, with the nasopharyngeal acting as the comparator specimen. And there was almost 100% negative percent agreement of these specimens. Likewise, at the same time, a group out of Stanford under the leadership of Bonnie Maldonado was conducting a similar study looking at patients that were previously identified as COVID positive, who then returned to the drive-through clinic for subsequent testing for the purposes of this study. And you can see similar results where there was very good positive and negative percent agreement amongst the oral pharyngeal comparator and the self-collected nasal swab. And this really set the precedent for the notion that a nasal swab might be an accessible and acceptable specimen for SARS-CoV-2 testing. Both of these studies have recently been published, one in the New England Journal in a letter, and the second in JAMA Online, most recently last week. So as we were looking at the nasal swabs and the notion that these could be used as an alternative specimen type that could be self-collected by a person, not by a healthcare provider who's gowned in PPE, but rather within, for instance, a person's car at a drive-through clinic, it became clear that there were other constraints on the supply chain, and that nasal swabs like NP swabs are also in short supply. The original studies were conducted with the Puritan foam swabs, but an alternative type of swab, a spun polyester swab, was available, but in a more plentiful supply. So studies were conducted by the Everett Clinic and the Quantigen laboratories in Indianapolis to evaluate the comparability between the spun polyester swab and the Puritan foam swab for a nasal self-collection. The polyester swabs were actually demonstrated to have equivalent performance to the foam nasal swab. And as I mentioned before, the polyester swabs can be manufactured at a much higher capacity than the foam swabs. Since the time of this work, additional manufacturers have come forward that are interested in manufacturing those polyester spun swabs. But those manufacturers don't currently have individual packaging or sterilization capability. That additional functionality is provided by external third-party providers that are registered with the FDA. Another question was around the issues of the limitations in the supply of viral transport media, and the question of whether in the setting of a nasal swab, either foam or polyester, whether there might be a substitution of saline for the VTM. And in fact, those studies were conducted in conjunction with the Everett Clinic and with Quantigen, and it was demonstrated that indeed the foam and polyester swabs performed very well, gave equivalent performance when they were collected and transported in saline as compared to VTM. And in fact, the saline specimens perhaps had better concordance amongst themselves and seem to have more stability. In addition, dry swabs were collected and tested in the laboratory, and that work was further extended with targeted experimentation that looked at the stability of nasal swabs that were collected either with a foam swab or a polyester swab, and whether those would be stable over time out to past 3 days, and whether those would be stable under a high temperature excursion to 40 degrees centigrade for 12 hours, followed by elevated temperature for variable lengths of time. This work demonstrated that the dry foam and dry polyester swab were both very stable and could be stable past 48 hours, and in fact were still stable in a very dilute specimen down to 2 times the limit of detection out past 3 days. And this was really very interesting to us because it gave us a window as to whether it might be possible for people to collect their own specimen at home and then ship those into the laboratory for testing. Indeed, conversations have been ongoing with the FDA, and additional guidance and direction has been obtained. In fact, a home collection kit has recently been approved by the FDA and is manufactured by the company Everlywell, who has been able to reference these data of the dry foam and the dry polyester swabs and their stability studies in order to use those as a reference in their EUA submission for home collection. So at the foundation, we've envisioned a sort of new paradigm for a home collected specimen that uses a nasal swab and doesn't necessarily require cold chain for transport to the laboratory. This would be a very inexpensive home collection kit comprised of only a small number of components, including a spun polyester swab that would be individually packaged and sterilized, that would have a QR code on it, a barcode, in order to allow the patient to access collection instructions and shipping instructions. Of course, the test would not be conducted in the absence of a physician order, but this would enable a person to collect their own specimen at home and really shorten the process and the time from testing to return of results. The swab then would be placed in a dry tube or in saline. We were also able to demonstrate stability in saline out to 48 hours, and that those samples could be shipped into the lab through a private logistics provider. Eventually, that may be enabled by shipment in the mail. I mentioned also that no cold chains required and that the samples are stable. So having a home collection kit for nasal specimens really opens up a number of different potential opportunities for testing. I know many of us have really been focused on testing within the traditional laboratory structure that we have in the developed world, but there are other testing models that we explore at the Gates Foundation for use in low and middle income countries. Of course, we talked about the laboratory setting that would involve individuals collecting their specimen at home, that they would receive a sort of activation of that swab and the kit for testing and collection of their specimen themselves by a prescription that could be afforded through telemedicine in conjunction with the symptom screen to make sure that the people that wanted the test would be appropriate for testing. The kits then could be sent to the laboratory and have been collected using instructions available either in a trifold in written form or by using the QR code to access online instructions with visuals for collection. And then the test would be provided by the laboratory with results returned either via telemedicine or through a traditional means through a healthcare provider. In the setting of low and middle income countries, however, less structured and sophisticated healthcare settings abound. And the idea that at a health post with a minimally trained community healthcare worker could also enable collection of the specimen by the patient, and the samples could then be transported to the lab using those same means that I described. In other settings, it might be possible to have collection of a specimen or dropping off of the specimen at a pharmacy or another clinic using models that have been described for the commercial pharmacies in the United States as well. And so we're hopeful that by lowering the barriers to self-collection of a specimen and by demonstrating that nasal specimen is appropriate and accessible for patients for SARS CoV-2 testing, that this will enable and extend the capacity for testing throughout the developed world, as well as in low and middle income countries that have less well-developed system. Moving forward, we can imagine a model whereby these three scenarios might be applicable for upcoming flu season and other, looking at other pathogenic viruses where it could use this same model for collection of the specimen and testing in the laboratory. Moving forward and out to low and middle income countries, we think a lot about the lateral flow testing formats that Dr. Slev mentioned when she was discussing the serology testing. This is also an applicable method for use in rapid diagnostic tests for direct antigen testing that could be useful for diagnosis. And so we're hopeful that by extending the studies of the self-collected nasal specimens, that we'll be able to demonstrate that indeed the same collection mechanism could be useful for direct antigen testing in less well-resourced settings. Those of you that are familiar with malaria and other types of testing that occurs worldwide, you'll know that lateral flow assays can be manufactured at very high scale and at very low cost. I believe the malaria tests are now maybe purchased by the ministers of health and the countries in Africa for as little as 18 cents per test. In some cases, these are supplements, but it is really true that the cost of goods sold for these lateral flow tests is on the order of pennies and not dollars or tens of dollars as you might see in the developed world. We're hoping then that the nasal swabs will enable the proliferation of rapid diagnostic tests that will also have high performance similar to molecular testing. And indeed, those test development efforts are underway with a number of the major IVD manufacturers in the US and worldwide. And I just wanted to end here with the potential for a future scenario of ultra high throughput molecular testing that might be suitable for use in the developed world, like in the United States. And the idea is really to leverage the technology that has been extensively developed and employed by the agricultural biotechnology industry, whereby millions of tests can be can be produced per day and tested per day at a single laboratory setting, where the cost per test is less than $1, and in some cases each individual molecular target can be tested at 10 cents or less. This might be a way to more broadly distribute molecular testing to all people, regardless of their insurance status, regardless of their access to other types of healthcare. Again, would be under the direction of healthcare providers and with a prescription, but this would really lower the barrier to much higher levels of testing that might also be useful in the event of returning to work, maintaining the healthcare workers' status as far as infection-free, also looking at schools and opening up broader institutions for larger collections of people. The idea of using a self-collected swab and a dry tube allows for shipping without cold chain, so that would make it much less expensive. And if these testing sites were distributed to airport areas, it might be very simple for transportation and very rapid turnaround of results. Of course, there are challenges associated with using a dry swab in a tube, which would require the laboratories, and in this case, the high throughput laboratory, to set up some kind of automated accessioning and elution of the specimen from the dry swab. But indeed, efforts are underway to produce and develop and validate that bridging step that would allow for those specimens to be put into the high throughput setting and would be applicable for millions of tests per day for each of these distributed sites. So I think I can stop here and turn it back over to Carl. I don't know whether there's time for any questions or whether you'd like to move on to the panel discussion at this time.
Well, first of all, thank you very much, Dr. Heichman, for that excellent presentation of the activities ongoing that you're spearheading at the Bill and Melinda Gates Foundation. I'm going to do one question and then we're going to switch over to the, back to Emily to direct us on how to do the breakout, the panel. The question would be, where might you envision how an individual would obtain the self-collection kit? For example, if they're on the telemedicine conference with their physician or other healthcare provider who says, I think you should be tested, where would they go to get the self-collection kit? Would it be, for example, right on the shelves of multiple pharmacy chains across the country? Where are you envisioning these self-collection kits would be?
Right. You know, in a perfect world, we would actually like to see a pre-positioned swab in the home, in every home, so that upon new symptoms arising, then a communication could happen with the healthcare provider, a prescription could be obtained, and the person could obtain their specimen for themselves at that time. So by enabling a very low-cost source of these swabs and having them distributable through doctors' offices and pharmacies and workplaces and schools, people could have them at home and rapidly collect their own specimens at that time. Now, the FDA would like to, I think, hold off on that notion at this point, although they are definitely amenable to a home collection scenario, but they want to make sure that there's a very strong tie to the prescription. And so we're hopeful that as we migrate into the future, it might be possible to enable the swabs to be distributed, but only activated upon a physician prescription. And I think the barcoding on the label of those swabs would enable that. So the patient could be registered at the time, and then that swab would be activated for having a prescription through that electronic communication, digital communication.
Great. Okay. Thank you very much. Well, you're going to stay on for the panel. There's probably additional questions related to this kind of effort.